Wonderful. Well, thank you so much, Azizi, for that wonderful talk. That was just so thought-provoking and inspiring. We speak a lot of the same languages, so I'm an informaticist from the Department of Learning Health Sciences. My name is Rachel Richesson, and I'm going to talk a bit about what my passion is, and I hope complement some of your ideas about the matriculation piece for scalability. So I'm going to talk very quickly about regulations and data standards, and I'm hoping I can stay in my time frame because I can talk for hours on this topic usually. So let's just start with a few questions to ourselves. So why have digital apps really failed to scale, right? Why can't every step or measure that's tracked on a wearable be used to inform clinical care and research? Any thoughts? What are the challenges? Close enough. But I was going for why aren't these integrated into our EHR systems, right, as part of our workflows. And I'll just go to the punchline. I think anybody that's involved in a clinical setting can really understand it's this lack of interoperability, right? And by that I mean data collected from one system just can't be meaningfully used by another system. And we see this in clinic with moving from clinical data to payers and bills, to quality measures, to decision support, where knowledge bases may be off-site. And then we certainly see it with home data coming from patients where they are from devices. This interoperability just really is not there. Luckily in informatics, we have a home for that. We have a federal agency called the Office of the National Coordinator, which is established in 2009 as part of the HITECH Act. As of last year, they are now called the Assistant Secretary for Technology Policy, but they're the organization that was responsible for really promoting the wide adoption of EHRs that we see now, and for starting the program that continues for EHR certification. And then the ONC has now also become the stewards of the technical pieces of the 21st Century Cures Act, which a major push of that is to mandate patients to have full access to their data to engage and participate in their care. 21st Century Cures also is responsible for data and information blocking, regulation, and enforcement. Really, providers and vendors are expected to share and exchange data. And further, the 21st Century Cures Act specifies that there should be a API, application program interface, easier ways to get data using FHIR as the data standard. How many people have heard of FHIR, the term FHIR? Is that? Okay, a few. So I'm going to do some really just quick intro to that. And the US Core for Data Interoperability, USCDI. Has anyone in the audience heard of that? This is something to watch. This is what's almost, you could think of as common data elements, classes of data that we can expect to be supported by certified EHRs, which is Epic, Meditech, Alltech, right? A standard way for representing data. So all of this is managed, this USCDI program, through the Office of the National Coordinator. And what is very exciting, and I encourage you all to have a read, although it's a pretty dense packed proposed rule in the Federal Register now called the HTI 5, Health Data Technology and Interoperability Proposed Rule 5. It talks a lot about standards. It's expanding sort of what these mandatory data classes will be. It doubles down on FHIR. It is really saying FHIR is the standard for health data exchange, and not just for reading from EHRs, but from writing to EHRs. And really, it's all in the spirit of 21st Century Cures, which was to allow patient access to data. So this idea that EHI, your electronic health information, should be accessible, exchangeable, and be able to be used without special effort. So organizations and vendors are on the hook for doing this. And so I'm going to give you a quick intro of what this is. First of all, FHIR is sort of a container, and it complements different code systems. So I want to just alert you to just three code systems recognized as standards in the US: LOINC, RX Normans, Nomad. Do these sound familiar to anybody? Any of these three? Great. LOINC is a code system for laboratory values, but also questions and answers, measurements, observations, the things that you may be collecting in these devices. So steps per day, hours per sleep, those kinds of things will all be in LOINC. RX norm, standard for medications, generic names, branded products names, and then SNOMED CT is a global clinical terminology. We use it right here with the problems in our problem list, and so everything at Michigan Medicine is underlyingly, you may not know it, but it is in SNOMED codes. And the scope of this is really everything in the electronic health record. So it's got conditions, findings, signs, symptoms, healthy, normal observations, things that go beyond what we're used to seeing in ICD. So these are all standard code systems that if you use, you will position yourself to integrate your mobile health digital app data with EHRs. But it still doesn't tell us everything that we need to know. It still doesn't get us, LOINC can tell us the measure is a steps or the measure is a type of activity. But it won't say, is this the most recent measure? When was this collected? What device? For medications, RX norm will be very specific on the medication name, but it won't tell you if it's a prescribed or deprescribed or if it's a statement. And similarly for SNOMED CT, it might tell you, it won't tell you if the symptom is present or the symptom is explicitly absent. So FHIR is something that is sort of a really loose data model that can absorb and use these coding systems, but provide us a standard way to look at this data. So this is a modern API data standard. It's free and open. It's built for software developers, so it's kind of hard to read and understand. So I'm going to give you my interpretation of it. But think of it this way. It's just a lot of different building blocks, simple standard representations for common data types that can then be combined into different ways. So it's layered. So there's some foundations, there's kind of some boring tech stuff on the bottom. On orange, there's certain data classes that are common to everything. Patient, practitioner, these things have ID numbers, names, addresses, that type of thing. And then building on that, we've got the green, blue, and red areas, these clinical clinical workflow elements. So clinical allergies, conditions, family history, procedure, care plan. Each one of these has associated attributes with them in a standardized format of what is important to know about those types of data. Diagnostics include observations, report, image studies, genomics, and then there's a medication group of FHIR resources with data resources around request, administration of a medication, a dispensing of a medication, or a statement that a patient has or has not been on a medication. And then there's other FHIR resources about workflows, referrals, appointments, tasks, communication, and then others about just the financial stuff, the bills, the invoices, that type of thing. So each of these data types can be a building block for a certain data use case scenario. So you can combine these FHIR data blocks, use what you want if you're a developer of a program, and create a FHIR implementation guide that then could support the different workflows. So here's just one example, the physical activity implementation guide. This exists and is built around the workflow where a provider would sort of assess a patient, make some kind of observation or judgment, propose a plan. That plan may be to monitor a coach, or that plan may be to refer to an outside provider or service, a gym, a coach, an app, right, to improve the physical health. And then the data from that service provider or that app would then come back to the provider for monitoring engagement and reporting. So these are sort of the broad workflow levels. And then, let's see, at the bottom, the FHIR resources, the building blocks you pull from FHIR to sort of create a guide for what that technical implementation of that workflow would look like. So I highlighted the physical activity guide. There are hundreds of these, and many of them are sort of ready to be field tested and tried. So there's continuous glucose monitoring, home blood pressure monitoring, the international patient summary, widely used across Europe, a snapshot of your data for traveling between countries, and a patient request for corrections if they see errors in their data. So as I begin to wrap up, I want to think, why does FHIR, I want to emphasize, how does this affect digital health research? Well, standards enable this EHR integration, which gives us the scale that we were talking about. And then you have patient value plus scale, and then that's impact. So just to summarize, federal policy is creating incentives and requirements for standards-driven innovation, and regulations are aligning the whole industry around FHIR. Future funding, dissemination, and scaling really demands compliance with this and interoperability. And the train's leaving the station, and FHIR plus your standardized coding systems are what will get you there. And then for my last slide, I just want to highlight how you can bring this into your research. So find the relevant FHIR implementation guides around the devices and programs that you're interested in, or engage in one of the working groups. Use these standardized code systems, LOINC, RxNorm, and SNOMED, and FHIR. Include this in your methods, and tell the standards and scalability story in your dissemination and sustainability sections. And look for funding. CMS, ARPA-H, FDA right now have open calls looking for digital tools, and I think combined with this FHIR piece that all these agencies are supporting, you've really got the potential for impact there. So I posted a link to different funding opportunities and summaries and some fun videos that sort of illustrate some of these guides a little bit more. So I hope that is a good start for you.
Good morning, Kathy and Azizi. Thank you for the motivating start. And I hope that the self-service analytics strategy I'll talk about fits within your vision as well. So self-service analytics has a lot of definitions, but one common definition is the one that you see right now, which really says that if you give people tools and access to data, they can go and generate insight. And I think in some respects this is true, but it's also incomplete. And so what we would like to propose is a different definition, a definition that is more operational in nature, more detailed. And we tend to look at self-service analytics as an adaptive system. And by that we mean that everyone participates in decision-making. This is not in IT making decisions and then disseminating those decisions. It's a collaborative approach. And it's an approach where it's self-correcting. And this participation allows us to basically adjust and adapt that ecosystem based on the community involvement. And this definition is based on three key pillars. The first one is, in essence, to democratize data and platforms, not tools, platforms. I'm being very specific in saying platforms. And here democratization is not only about access, it's about, in essence, ownership. So we have a collective ownership of this ecosystem. And then the next one is about production. And this is a tough one for a lot of people because developing solutions is relatively easy. It's when you want to integrate them with Epic. It's when you want to basically maintain them on the long term. Are they scalable? Every time we develop a solution, we're actually adding extra cost. And so the question is, how can we make this process more automated, more scalable? And then the third pillar is, in essence, about collaborating and building this collaborative innovation network where everyone participates, not just in sharing information, but in governance. IT should not be exclusively in the governance business. It should be a collective effort. And just imagine if someone has a question about a particular problem, instead of building a report, they can basically ask the question, and then if someone else had solved this problem, then they would be informed of that solution. And here's a view of the ecosystem we are proposing. And it's a lot of information to digest, I know. But in essence, it's built on Microsoft Azure. And we are in the process of launching Fabric in production. It'll be implemented sometime this year in some fashion or another. And that allows you the ability to do full lifecycle analytics. So you can start with data preparation, you can develop models, you can launch those models. So that's one major component of the platform, and obviously you can store the data. I know, Kathy, you talked a lot about that this morning. So that could be a mechanism with One Lake where you can actually do that. The other initiative is Power Platform. In March, we're launching Power BI, Power Automate, and Power Apps connected to M365. So you can use it within the M365 environment. However, you will not be able to connect to databases like SQL Server or Oracle. In phase 2, we plan on launching Power Platform as an enterprise solution, which means that you'll be able to develop chatbots, develop agents, and use the full AI capabilities and basically tap into any data source. To do that, we need to hear from you. We need to hear about use cases. We need to hear about the problems you want to solve, and then we can collectively work on setting up that initial implementation to support you. Beth Plotz, who is sitting in the back. Beth, you want to raise your hand? She's leading this effort, so feel free to connect with her as well, and she can give you a lot of details. But that's in essence the ecosystem that we are promoting at this point, but we definitely welcome your feedback on it. And technology is not enough. We need an operating system, and we are launching in conjunction with the technology a franchise model where, just like McDonald's, they basically say, okay, here's a setup of your store, the equipment, the French fries machines, the registers, and here's a playbook for how to run, a store. You'll be able to run in analytics an AI store. And this store, unlike maybe McDonald's, you can choose to have a small store, a large store. You can have a store that we can run for you as hits. So different configurations based on your needs, based on your maturity with the analytics. So it does provide that flexibility. But in essence, we will be providing this franchise agreement, and part of that you'll need to contribute to the community with best practices. And then again, we're going to have a community practice where it's not just about sharing information, but it's about governance as well. We need everyone to be engaged in shaping the direction of this franchise model and ultimately the technology and the solutions. So that's it. Hopefully we can carry this dialogue beyond this meeting as well. Thank you so much. Appreciate it.
Good morning, everyone. My name is Shriya Anand, and I'm a clinical research assistant with the Mobile Health and Adaptive Interventions Lab under the mentorship of Dr. Adam Horwitz and Dr. Eva Sis. And today I'll be presenting on text-based support for caregivers of suicidal youth. So just a little bit of background. As many of you may already know, recent mental health trends have seen an increase in pediatric emergency department visits for suicide risk concerns. And caregivers of these suicidal youth often leave the ED feeling very overwhelmed and uncertain and alone in navigating how they can support their child. And in that process, many of them neglect taking care of themselves. And in a fast-paced environment like the ED, providing individualized support for these caregivers is quite challenging, and we find that providers are often very strained in their own workload. So there's a need for a low-burden and scalable solution that can support these caregivers without adding to their workload. So here, we think it's important to ask these providers for feedback to understand what the barriers and facilitators are to implement a new intervention in these settings. So a little bit about the intervention itself. The intervention is called TESP, which stands for Text-Based Support for Parents. And this is a pilot trial that we completed recently with 120 parent-youth dyads, and that showed pretty positive caregiver acceptability. And we just recently started a larger trial that is designed to evaluate and optimize the intervention package. So that'll include like a JEDI and an MRT, but today's focus is more on the feedback side and like what we heard from the stakeholders about this intervention. So this intervention has two components to it. It has an adolescent-centered component and a parent-centered component. So these are automated text messages that are sent to these caregivers, and the AC, or adolescent-centered text, will cover how the parents can support their teens. So things like recognizing warning signs, how to strengthen their connection with their teens, and encouraging coping and tips for communication and providing support for their teen. And the PC techs are more focused on how they can take care of themselves. So just like self-care and coping tips and encouragement and affirmation for themselves. And this also includes like parent testimonials, so they can know that, they're not alone in this situation. So as part of this first phase of the larger trial, we asked stakeholders for their feedback so that we can iterate and further refine the intervention design. We had 21 stakeholders across 3 EDs from 2 different Michigan health systems, so University of Michigan and Hurley Medical Center. And most of our stakeholders were social workers. We had physicians, nurses, and also some other staff like medical IT staff members. And most of them provided direct patient care from around 3 to 5 days per week. So we presented these stakeholders with a sample of the text message intervention, and they participated in semi-structured Zoom interviews, and we collected quantitative ratings on Likert scales assessing content, utility, appeal, and feasibility of the intervention. And the transcription of the interviews were done through the Zoom's automatic transcription feature, and then we cleaned that up and prepared it for analyses. We conducted a rapid qualitative analysis, and our team developed some thematic framework across the different interview domains. And we had 2 independent raters code the transcripts, and then they used the framework. And then we had a final rater who reconciled the discrepancies, and we calculated inter-rater reliability. So just some general results. So we have ratings for how much they liked or disliked the AC and PC components of the intervention. And as you can see here, it was pretty high from 1 to 5. We had a mean of 4.62 for the AC component and 4.48 for the PC component. And as for the utility of the intervention, if it were to be implemented as part of routine care for these families, that was also pretty high, so 8.14 out of 10. So more on the AC text, the stakeholders liked that it provides supports for the parents, and also that it's accessible and has an efficient setup. So these text messages are easy to roll out. But they did mention that it may not be engaging for all parents, and that maybe the content may not be helpful for all parents as well, and that a lot of times these families come into the ED looking for something very specific, like a specific type of therapy or a medication or a diagnosis. And for the PC text, we also had some mixed reviews on it. So we had some stakeholders feel that it was well aligned with the needs of the parents, and that, for example, like sometimes they come in and they need a reminder that they need to take care of themselves in order to take care of their teens. And some of them felt that it was not very well aligned with the parents, and that maybe they want to focus on their teens and not themselves in these times. Some other broader metrics, we looked at appeal, applicability, and implementability. And these were rated pretty high too. So out of 5, appeal was 4.65, applicability was 4.4, and implementability was 4.2. If you see here, implementability is slightly lower than the other categories, and this may be informed by some of the barriers that they shared with us. So they did mention that parent receptivity and readiness is an issue, and not all these families would be wanting to buy into an intervention like this when they're in such a high stress situation. And also, sustaining this intervention long-term in the EDs would be a concern for them. They also highlighted some technological barriers, and that some people don't have access to a phone, or they don't have, or they have like data limitations, so they're not even able to receive these text messages. Facilitators included clearly defining staff roles and giving extensive training, and they wanted to kind of identify a team member or like a champion who would kind of lead this initiative. They also mentioned that having clear explanation about the purpose and the benefit of the intervention would be important for both staff members and the parents of these teens coming into the ED. They suggested automation and efficient delivery systems. So for example, if it's like a quick click on the medical record program for them to just start this intervention. And the general sentiment that we heard from these stakeholders is that any help is better than nothing, and that parents would welcome any support, ongoing support. So to conclude, we have some key takeaways. So stakeholder engagement is really important and helps us reveal these workflow, staffing, and infrastructure considerations that are critical for implementation. Also, feasible low-intensity tools like text messages are particularly well-designed, well-suited for acute care settings like the ED. And finally, we should really try to intend these interventions to be designed for long-term integration when we want to have them be helpful for health systems. And yeah, thank you all for listening.
Hello, everyone. I'm Yu, working for Intern Health Study and Campus Study. And today, just wanted to talk a little bit about the sensor kit data we use for the mental health research. Touch a bit based on what is it and what does it include, and how to include that in the research study. And we have used it for intern health study for 2 cohorts, and what we have found so far. Sensor kit is a framework built on various sensors existing in iPhones and Apple Watches. It is passively collecting data from all kinds of environment or how people interact with their phone when they're having their phone watch. It's for research purposes only, and we believe that these extra data types could help to give us more knowledge about the mental health research and probably help to develop more real-time interventions to improve the well-being. So what data does it have? So here's a list of the sensors we choose to include in our study. So there are light exposure, device usage, keyboard, message and phone calls, speech metrics, and visits. I think there's a few more available as well, but this is the main ones we chose to include in our study. So the overall spirit is the data collected is more about the description of the meta overall, the picture of the data, but not the specific contents the participant actually provide. For example, like in the keyboard metrics, the sensor kit provides like the typing duration, the speed, the accuracy, or the screen size, but not the actual words typed. And another example is like for the visits, the sensors provides the type of the locations or some anonymized identifiers of locations, the distance from their home, but not the actual address and GPS or the name of the places. So it's give you more information, but at the same time protect the privacy of the participants. To include this in your study, first you need to obtain approvals from Apple and IRB and with a specific study plan, and then use a either existing platform like we use My Data Helps, or develop an app to obtain consents and also connect with API to get access to the data. You need to get additional consents from the participants, and this is for each data sensor type. They can choose, like say, okay, I want to provide my the data from my light sensor, but not the speech. That is allowed. And the last but not the least, they are very big in data size, so we have to be prepared for that. We had great help from HITS, a team, to use the HITS database, but also I think there's other resources like the DataDan. So it's very granular. So if you have hundreds of subjects and collect the data from months like we do, you will be facing gigabytes, many gigabytes of data. So, and also try to convince the participants this is not like poking your private life or anything. So give them very detailed information about what this data is about. And we have got pretty nice enrollment. So among our already enrolled subjects, half of them agreed to participate in this sensor kit arms of the study, which we are very happy about it. So far we have collected the sensor kit data for two annual cohorts of our the InterHealth study, which is a study on stress and mental health on medical interns on their first year residence. So I'm gonna just briefly talk about some of the some of the findings we have already found. The first one is we use a keyboard metrics to extract their typing speed and the typing accuracy, and relates that to the the times awake with the help of our wearable data. So we found that specifically typing speed is closely related to the hours awake. So it reaches to the peak around 7 hours awake and drops to a below 0.1 standard deviation of their personal average around 15 hours, which is very closely aligned with the lab-based fatigue study. So this shows some potential that a real-time monitoring of your typing speed could signal the mental fatigue. Another project we have done is to utilize the visits data just to see, so the data can kind of tell you when you're at home, when you're at work, but when you're at some other places. We call these non-home and non-work places as the third place. So we kind of, from the left-hand side, the more granular data, we extract the daily metrics of the percentage of time spending those third places, and as well as the number of unique places you have visited on one day. And we find that both of them are related to higher mood. So go outside. Another thing we have used is the light sensor. The left-hand side is a kind of overall average of our interns, and you can see that their light exposure just like dramatically drops after their internship started. And then we found on the right-hand side is that actually the percentage of time exposed to like the outdoor level light is positively correlated with higher mood. So poor interns, but you're not interns, you can go outside. So these are some of the findings we have already done, but we are definitely working on with other sensors. Like we have some ongoing projects looking at speech metrics and mood prediction, and as well as some phone, like the social connections. We learn from the phone message and social network app usage and the mental health outcomes as well. But in the future, we are hoping to kind of combine all these multi-modal, multi-sensor, and wearable data together to get a much better comprehensive model or intervention prediction on it. And of course, there are individual differences as well. Like what I just showed is our like average trend, but different people are different. You probably will see, learn some, Mon gonna present some of our wearable individual differences, correlations later today. So we're gonna want to apply that to the sensor kit data as well. And then maybe expand this analysis to other populations, for example, like the mental health patients in the COMPASS study. So I want to thank my team, and that's it. Thank you.
All right, we're now going to open the floor for questions and comments. All right, I can start. Rachel. So I'm a physician here. I'm a sleep neurologist, so that's like the only thing I know about, but I hope this applies to people in other areas. So I think that interoperability has become like a massive problem at Michigan Medicine. And I did not realize that there were like legal and compliance standards about this, but there's also these competing interests that I've seen that seem to interfere with that spirit. So, for example, there's financial competing interests, and there seem to be legal competing interests. So in sleep, we have, obviously, we operate primarily within Epic, but our in-lab sleep studies are in another cloud platform. The data from our patient CPAP machines, which is primarily what we treat as sleep apnea with CPAP, that's in another cloud platform. And then we have home studies that exist in another cloud platform. We've spent about the last 7 years trying to get interoperability between Epic and the CPAP cloud. And from a technological standpoint, it was feasible. The ambulatory integration team was ready to do it, but there seems to be these competing interests because the manufacturer bought a company that makes middleware, and the middleware company isn't interoperable with the in-lab sleep study software. And then the manufacturer won't sign a data protection agreement, and OGC won't approve that. So who has the oversight for this, and how do these competing interests get balanced so we can actually practice medicine with all these digital data sources?
Wow. Should I jump up here, I guess? Wow, yeah, okay, great question. I think, well, in the language of learning health sciences, learning health systems, I'll say, yeah, it's a complex, wicked, socio-technical problem, right? So interoperability, the standards I mentioned, they've been around for decades. We have them. The bigger challenge is, yeah, incentives, organizations wanting to do it, that type of thing. It's fascinating to see how things change so quickly, and I didn't really cover it in my slides, but I will say the new presidential administration and what they're doing with CMS is all about patient engagement and technology. And so they're trying to reduce, I think, some of those barriers. They're also, that proposed rule I said is also taking away a lot of EHR certification stuff that sort of the argument is that's already baked in, so we don't have to have that burden to new innovators to do that. So we can remove some of these functional things that EHRs do anyway, and we can sort of deregulate and allow more innovation and simplify, et cetera. So they're removing a lot of stuff, and they're doubling down on the data, though. And so I think through like CMS and other organizations, but incentives to practice, like if we get to the point where to an organization that data affects how they practice and the outcomes, and I think that's where we might see some movement there. So I think it's, yeah, there's lots of people sort of getting at this, and you're right, the data standards really are about 5% of the problem, and the rest is everything else. So, but it's a fun, wicked problem to all work on together.
Any other questions for our presenters?
Hi, this is a question for Dr. Raad, and it's a controversial question. So I'm a quantitatively trained researcher. I'm a statistician, and I've seen bad science. I've seen a lot of bad science. So when I see self-service analytics, my heart palpitations go up. How do you view the human in the loop? I mean, with AI, we know that it couldn't even do the reference as well. If we outsource our whole analytic pipeline, I'm worried for the science.
Thank you. That's really a very fundamental challenge that we face in this discipline. What I would say is that the human in the loop, at least for the foreseeable future, is a must. This is where we need the experts to be involved. So to me, it's not, okay, here are some models that you can run and we'll see you. It's really let us work together so we have experts from different areas collaborating to solve a problem. The human in the loop is a form of active learning where you always need to be trying to correct, if you will, the implementation and give feedback. If it's an AI solution, give feedback to the AI solution. But one of the things we're doing right now is we're looking into launching a monitoring platform, right? Where every model that is implemented, at least through the Clinical Intelligence Committee, would be subject to this monitoring standard. And so there are metrics will be generating early warning capabilities, and these capabilities will be standardized. So, no one will get a free pass from that point of view. And so we'll launch it, we'll evolve it, we'll keep on improving it. But to your point, even though you have even today LLM as experts implemented in the monitoring process, we need people to actually look at the data. And here we would make a distinction as well between the significance of the model in terms of their correctedness and also the clinical significance. So you could have a model that's really very good and it checks the boxes on all the metrics, but then from a clinical point of view, it's not necessarily having the right impact. And that's not something that the data science individuals can really solve. It's a collaborative effort, with the clinicians and with the experts in that area. But that's the latest effort we're trying to put in place right now, is this standardized monitoring platform for all the models.
I guess my only question is, who is monitoring the monitoring?
We are, in fact, trying to identify experts around Michigan medicine who actually act as like an oversight. I don't want to say it committee because it's a working level team. They're really experts in algorithms. They're experts in some clinical domains. And so I think we are very careful in terms of making sure we have kind of this mechanism to protect. We understand that patient safety is at stake over here. There is reputation risk. So to me, this is my background is in risk management as well. So quantitative risk management. So we're looking at the problem as a risk management problem. But you're spot on. Your concerns are concerns that keep us up at night, because how do we solve this really wicked problem where the technology is changing every day and someone comes and they promise, hey, we've solved this and this LLM is going to do everything for you. Not true.
Thank you.
My pleasure.
All right. Anybody else? Okay, so while you guys are thinking, I have a question. So you listed these 1, 2, 3, 4, steps of working with SensorKit, and number 4 was expect problems. And so I'd love to hear about some of the problems that your study team experienced with the SensorKit data and how you address those.
Can you say that again? Like which sides, which problem?
No, on number 4, you said for using SensorKit, you said expect problems. So what were some of the biggest problems that you ran into?
I think the data collection is a big thing that you have to, and the data is pretty, I'm a data person, so the data is pretty messy in a sense that you have to do a lot of careful cleaning and structure, tabulation for the next step use. That's one of the problems. I think we still, and although we are satisfied about the enrollment rate now, but I think it could never hurt to get it be more welcomed, more acceptable. I think the data storage is actually a big thing. You have to be very prepared for that. I want to thank John's team and Siting and Joe have made a lot of effort on helping us on that.
Great. All right. Well, thank you for our lightning talk panelists. We are going to take a break, so everybody come back at 11:05, and we have our research spotlights.